Well, we are going to be talking about the connections between trauma, PTSD, ADHD, and more. And to do that, we have a special guest, Dr. Iris Manor. She's a senior child and adolescent psychiatrist, director of the Lifespan ADHD Clinic, Gaha Mental Health Clinic, Mental Health Center. She's an associate professor at the Sackler Faculty of Medicine in Tel Aviv University. She is very interested in research, having national and international collaborations. She's authored more than 70 papers on ADHD, which have been published in peer-reviewed professional journals. She is also a member of the American Professional Society for ADHD and Related Disorders, known as APSARD, the head of the ADHD section of WPA, and a member of the board of European Professional Group for Adult ADHD. And that's how we met. She gave a talk, part of a three-part talk on trauma and PTSD and related issues in ADHD at the January APSARD conference. She's also been invited to present her works in many international meetings, including APSARD, the ADHD World Federation, and more. So, welcome to the podcast.
Welcome. I'm very happy to be here.
Yeah, well, it's so nice to have you. To start out with a kind of broad question, but what is the relationship between ADHD and trauma?
Oh, okay. So the relation is not between ADHD and trauma, because trauma is, it's independent of our personal feelings or personal disorders. The relationship is between ADHD and the trauma disorder, traumatic stress disorder or acute stress disorder. There are several names for it. And the idea is that children and adults with ADHD are more prone to develop traumatic stress disorder and also PTSD. There is a work in Denmark, a study from Denmark, that showed that children with ADHD are around 11 times more prone to suffer from PTSD if they have ADHD, which is a huge number if you think about it. It's 11 times more PTSD risk to have PTSD. So that's what I said, that children and adults with ADHD are at risk for PTSD, and are also at risk for traumatic stress disorder. And this is why it is so important. It is important in every possible sense, clinically and even public health issues, and we have to be aware of it and to know how to deal with it.
A strong connection between people who have ADHD, you're saying, are 11 times more likely to have PTSD. Is that what you were saying from that study?
Yes, children with ADHD.
Yeah. In children.
11 times more.
Wow, that's interesting.
It's a study from Denmark, and the war there, nothing, national trauma that we are aware of, and still this is the number. So we see that trauma at large is a risk factor in children to develop PTSD.
Wow, why is it so common?
Very, very good question. And we have many answers, and we need to study all of them in order to see what are the better answers, scientifically based, and what is not, and what is evidence-based. First of all, we think that people with ADHD are sensitive, are more prone, because they seek novelties, and they are more prone to get themselves into risky situations. So this is one idea or one explanation, which is a behavioral explanation. And I also call it a bit blame the victim, because you say it's their fault because they do some things that make them more prone to suffer from traumatic stress disorder, because they put themselves in risky situations. However, there are other explanations, even neurobiological explanations. Professor Biederman and his team found several years ago that people with ADHD share biological mechanisms, neurobiological mechanisms, with people with PTSD. For example, networks in the hypothalamus and in the ventromedial prefrontal cortex, and they have the same flow in the connections there and the networks there. And also there are some studies about cytokines and the frequency of inflammatory cytokines in ADHD and traumatic stress disorder, in people who suffer from traumatic stress disorder. So we understand now that stress can be an inflammatory condition, and it may cause the traumatic stress disorder. And people with ADHD also tend to suffer from some inflammatory mechanisms. We don't know yet what is the part these inflammatory mechanisms play in the whole picture of ADHD, but we know that they are part of the mechanism. So inflammatory mechanisms are somehow shared. I hope this answer was not too long.
Yeah, well, it sounds like there's some genetic aspect, that there's a predisposition in vulnerability that is identified, and then there is an environmental aspect.
It's a very good question, because it may be inflammatory and genetic. We know that there are several genetic inflammatory disorders that are associated to ADHD, like familial Mediterranean disorder, G6PD deficiency, and others. We don't know enough about the genetics of the sensitivity to trauma. I'm not sure that there are no genes that are connected or related to it. And it may be a very interesting do a Mendelian randomization study to see if there is any causability that may lead from stress to inflammation to ADHD, but this is only a thought. And yes, we know that inflammation, it's not only of the child himself, it's also of his mother. Because other studies, for example, from Japan, demonstrate that when a pregnant suffer from trauma, their preborn child is in higher risk for developing ADHD. So it is transgenerational. It's not only the child himself who suffers the trauma, it can be the mother who suffered trauma.
And yet ADHD, we know it strongly has a genetic aspect to it as well. So it's hard to know if that's an added.
It has a lot of genetic explanations. There are many, when you do the GWAS, you see that there are many, how do you say it, the PRS, I forgot the word, that there are a lot of risky genes and there are a lot of risky variants and VTNRs that are related to ADHD. It's not one gene or the other. So the genetics of ADHD is the next one. And it involves serotonin, dopaminergic, GABAergic, and other genes. So we also think now that maybe inflammatory genes are also involved in the mechanism of ADHD.
So a question that came up at the talk at the APSARD conference was, which comes first, ADHD or PTSD?
The $10 million question. No, the question actually was if we see two disorders, ADHD and PTSD or traumatic stress disorder. It doesn't have to be PTSD. Most of the people who suffer from traumatic stress disorder don't suffer from PTSD. PTSD is a very severe disorder. And many people, we know it here in Israel now, unfortunately, suffer from traumatic stress disorder. They have some of the symptoms, but not enough symptoms to call it or diagnose it as PTSD, and still it is a disorder. And the question was actually if these are two different disorders, ADHD and traumatic stress disorders, that should be treated, or is it one disorder because it's mingled and you cannot evaluate what is the ADHD and what is the traumatic stress disorder in the complex picture that you see, because you see a patient, you don't see a diagnosis, and you have to diagnose him. And then you say, wait, is it one diagnosis or are these two diagnoses? I myself believe that these are two diagnoses, but we can argue about it.
So it sounds like there are people who get exposed to trauma, right? There's types of trauma, and when you have ADHD, you're more likely to have impulsive behavior. So you might be a little child who runs out into the street without looking, gets hit by a car or a bicyclist or something, gets injured, or jumps off playground equipment, breaks their leg, or an adult who is more prone to get into a drunk driving situation and get in an accident or injury. maybe in a romantic relationship may be more casual without thinking and be put into a vulnerable sexual position and may be, assaulted in other ways. So there may be aspects that people with ADHD are more prone to trauma, not that they're intentionally seeking it, but they're by their behaviors. And then there's trauma that occurs that is more random. Think of innocently driving down the road and somebody hits you, or in a war situation.
You talk about physical trauma, and I'm also talking about physical trauma, but what I was thinking about was abuse and sexually abuse, being sexually abused, because the two dangers that children with ADHD are prone to are to be abused. You can say that it is because of their behavior. Again, I believe that it is partly blaming the victim, but they are more prone to be abused. They are more prone to be sexually abused, not only as adults, but also as children, because they go to see the puppy and they are impulsive and things like that. However, there are other traumas that are not dependent on you and your behavior. It's not because you drove a car and not because you went to see a puppy. These are traumas like Hurricane Katrina. These are traumas like somebody dies in the family. These are traumas like a war, like in Israel or in Ukraine or in other places. And all of these are traumas that are national traumas, that are universal traumas, that they are not dependent on your behavior. And still your response to these traumas, as somebody who suffers from ADHD, is different. You have to be more aware of the consequences of it. So if you are in a place when there was a huge trauma, people with ADHD should be one of your risk groups. You have to deal with them first because they are more sensitive, they are more at risk to develop something. Okay?
Yeah. And that's a very important.
Sometimes you cannot. And sometimes there are traumas, and you have to understand that this group should be taken care of, and nobody thinks about it. I must say that here in Israel, for example, and we have a lot of knowledge about trauma and how to trauma, the connection of this understanding, this knowledge, with knowledge about ADHD is very lacking. This is one of the things that I'm working about to change it.
And that's part of why we're doing this podcast interview, talking about this, to get this information out there so that families, loved ones, and clinicians who are working with people who are going through trauma to be thinking about this. It seems to be that it's not always on their radar. We've learned through COVID, for example, there's people who are at higher risk of dying from COVID. If you're obese, if you have high blood pressure, if you have diabetes, if you're hypertensive and elderly, you are higher risk. Not that everybody else can't, but you're going to be much more vigilant about protecting certain groups of people. We just know that in other medical issues, and this is just an awareness. Not everybody with ADHD is going to get PTSD, but it's a much higher rate. And if you see somebody who has PTSD, now one of the interesting overlaps with chronic pain syndromes, and this concept is that there is an injury and then somebody develops chronic pain. Sometimes there's emotional, there's a number of factors, and then it persists. There's normal healing time from an ankle fracture. In 2 months, people should have healed or so, for example. And there's trauma, as you say, there's an acute trauma reaction, but then it transforms into prolonged problems. When somebody has acute trauma, when somebody has an acute ankle fracture, they're going to be disabled. You can't walk on that. You have struts. Is that a similar parallel between that trauma and then that extending into this prolonged aspect?
There are several things that you said that I must acknowledge. First of all, COVID was a trauma. It was not only an infection, it was a trauma because it changed our world. And for many children, especially, it was very, very traumatic, and you made a big change in their behavior, in their social connections, and things like that. And by the way, children and adults with ADHD are at risk to be infected by COVID more than others, and are even they have higher risk to develop long COVID. And this was one of the main reasons that we began to investigate the relationship between ADHD and inflammation when we understood it. Until then, it was not very on the radar of everybody. So COVID is a very good example of trauma, and also a very good example of the association between inflammation and ADHD. The other thing you said is that yes, people with ADHD tend to suffer from pain more than other people. We don't know why. And I don't think there are many studies about it, if at all, the association between chronic pain syndrome and ADHD. I don't know, maybe you know more about it.
Yeah, actually, there's a lot of studies showing that in those who have chronic pain syndromes, on the low end, 30% prevalence, on the high end, 80%. And talking with Joel Young, who I just interviewed yesterday on the podcast, it'll be coming out later this spring, in his group out of Michigan, where he's done work with chronic fatigue syndrome, which is really synonymous in my mind, and most people so very overlapping with fibromyalgia. 70% had ADHD, so very high correlation. And that's interesting. That creates this.
So the fibromyalgia is not chronic pain syndrome. What I meant was that, as you said, if somebody breaks his ankle, he suffers from pain. And it seems that people with ADHD suffer more.
Well, and they're more likely to have that turn into a chronic pain syndrome. So the healing, now they're more likely to say I was fine, and then it all started when I got in a car accident. But now they're years later and they still have pain in their neck, and sometimes all over. Or they might have chronic regional pain syndrome where they hurt their ankle and now they have persistent symptoms. We think it has to do with the ability to filter out stimuli. Is less, and so all of the sensory, everything's felt, and it's harder for one aspect. The other aspect is often that maybe for the first time somebody's becomes forced to be very sedentary. Many people with ADHD naturally like to be very active, and suddenly they're not moving at all. If you break an ankle, for example, so suddenly they get into this cycle where they might have other co-occurring conditions. Maybe if you have a restless leg predisposition, now they're not exercising, not sleeping. All of this suddenly can turn into many problems. You mentioned long COVID. Now we understand, at least, and I agree with the experts in this area, long COVID really is fibromyalgia. I did an episode on that a year ago, and what they look at is all of the symptoms really meet the criteria of fibromyalgia, and it's just a different entry point. Some people have an acute event that kind of stimulates their fibro or unmasks it. Some people might be the whiplash car accident, acute trauma for some people, like, being sexually assaulted or something. And sometimes infections like a bad influenza or bad COVID, right? So all of these are complex and interrelated, and it seems like there's that similar aspect. And you're right, going back to just talking about COVID, I was thinking just the acute one-person infection risk of dying, or getting very sick is higher in certain risk groups. But then there's a societal impact we've had in altering just the normal flow of life. But you bring out how that is really...
This is a national trauma. Actually, it was an international trauma.
Yeah. And just all of the healthy supports I know there's a lot of different opinions, but I knew that the mental health, right when this happened, I'm like, if we don't open things up, this is going to have a really hard consequence on the mental health part of people. And it did. There were a lot of terrible consequences, mental health issues, suicide. People were really struggling. They might have been a child who loved doing sports, but they shut down the sports activities or their group play and dance or whatever kind of recreational things, and they were just sitting in a house. And many ADHD people don't get motivated to just exercise by themselves. It's often a competition. They like doing that. They need the societal input.
There are also eating disorders. There were also much more eating disorders. The idea is that this is the same when we talk more about, we are beginning to talk about treatment. And the first rule of treatment is to do discrimination between people who will heal by themselves, who have enough resilience, and people who will not. So you don't have to treat everybody. And this is easier when you don't have to treat 100%, but only 30% of people, because then you have more resources to treat people. And resilience is very important, and you have to have some rules in order to strengthen this resilience. For example, I mentioned it in a way, you have to have a schedule. And it's true about the time of COVID, and it's true during the war, that you have to have a schedule, even if the schools are closed, even if there is chaos around, a regular schedule that you have to stick to. And people with ADHD have a problem to have a schedule. And you also need to do some things and to have some goals to do things. I mean, really do things like, as you said, sports, helping at house, like washing dishes, like taking the dog out for 5 minutes. There are so many things that you can do that can help you to feel that you do something, that you're not helpless. This is very helpful against traumatic stress disorder, not to be helpless. And I think these two are very problematic to people with ADHD, and this is the reason why we say that people with ADHD must be treated for ADHD in order to avoid the traumatic stress disorder. And this is also something that is not known enough. In some places, they even stop giving the medications, stop giving stimulants to people who went through a trauma because they are afraid that the stimulants will make them more anxious. And the truth is, it is the other way around, that if you get your stimulants, it is easier for you to handle the traumatic situation you are in. And I mean the chronic traumatic situation, because the trauma happens. Something very awful happens, like in the south of Israel. Something awful happened in Katrina. But afterwards, there were chronic consequences to it. People had to be evacuated. People didn't have a home anymore. People lost loved ones. People lost many things. They didn't have school. They didn't have work. They didn't have many things. And this is a chronic situation. And during these chronic situations, if you are not fit for ADHD, you are lost. You are in chaos. So the first rule is having a schedule and having the goals and having your things to do every day. And the atmosphere at home is very important. The second rule is if you have ADHD, you must be treated for it in order to do all the things that are in rule number one. And I think this is very, very important, because this way the resilience is much better, and most of the people that I see, at least, are healed from the traumatic stress disorder, because let's say that October 7th, I think most of Israel, not only in the south, suffered from traumatic stress disorder. Many people were on reserve. Many children didn't know what to do. Many children were in bed in Tel Aviv, not only in the south or north. Many people were evacuated. And after 3 or 4 months, it declined to 30%, 20%. It could be much more treatable. We didn't have so many patients to treat because the resilience helped them to rebuild themselves out of the trauma, if you understand what I mean.
Sure. What
Again,
impacted the
they had
resilience?
a schedule. They got used to, for example, to alarms. At the beginning, everybody was afraid of the alarms, especially children. To hear alarms day after day, many times a day, it was very frightening. And then they got used to it. They saw that they can handle it, that there is protection, that it's not so random and so dangerous as it sounded to be. And then they got okay with it. People get used to many bad things if they have to. During Second World War in London, people got used to living the Blitz. So if you get used to something and you do the right things in order to continue your life, you can get resilient. Of course, it depends on yourself, on who you are, but most people are resilient.
And that's one of the important aspects, like you're talking about structure. There's a lot of different aspects that go along with that. But getting back to what you said earlier, if somebody has ADHD, treatment at the core, I assume, is for most kids is stimulant medications and also education.
Yes, and the problem is that many children were not treated or stopped. Sometimes even they stopped, the physicians stopped the treatment, which was horrible. But there is also another thing. You know, a child with ADHD, we discussed it earlier, that ADHD is heritable. So it's not only the child who has ADHD, many times the parents also have ADHD, and they are not diagnosed many times because adults with ADHD are not as much diagnosed as children. There is an underdiagnosis in adults. So the family is much more prone to suffer from traumatic stress disorder because the atmosphere is not calm, there is no quiet, there is a lot of stress that it's very difficult to handle. So the third rule, if we talk about rules of how to treat traumatic stress disorder when you have ADHD, the third rule is to see the parents, to diagnose the parents, to treat family, a child or an adult. Treat all the family together, because if you treat all the parts of the family, it's like a vicious circle that stops, that you can change it to a magic circle, but a positive magic circle.
Yeah. And so what you're saying is when you have a child who clearly has PTSD, this helps prompt you as a clinician to wonder, could they have ADHD or they already have ADHD, one of the two. You identify that. Children are a little bit less likely to mask their emotions. So get diagnosed. You should, as a clinician, be now screening the parents. This is likely genetic. One of the parents may have this. You should screen them also for ADHD and the PTSD trauma. And then if they have that, treat them with their ADHD and have psychoeducation. And that can help them put in and the child together.
Yes.
And that's what I do a lot in my practice is often when I make one diagnosis, the adult comes in, then often the child is coming in because the parent sees that, or vice versa. The child comes in and then the parents start doing these questionnaires on ADHD and they go, well, that was just like me. I think when I was a kid and I had struggles, I was talking to a parent this week. It wasn't to do with PTSD, but it was a 8-year-old getting evaluated for typical ADHD and attentive. It was high IQ, and had treated his brother, and then mom was thinking and says, he's not in a crisis, but she's like, I need to make an appointment with you because I need more help. And of course, parents sometimes worry about using psychotropic drugs on their children. So she's like, I want to see what works for me, and I'm going to make an appointment and get mine on top because I need to self-regulate myself and help myself function better. And then look at my son again in 3 months and see how things are going. And she's got an appointment planned to see me. So, and I'm a pediatrician and an internist taking care of kids and adults. So it's routine. I don't think that's very common that most clinicians are able to actually treat the whole family. Often then they're sent to many different clinicians to try to get a diagnosis. There might be months delayed sometimes in getting that diagnosis.
No, but I'm a child psychiatrist, but the idea is that's why I have a lifespan clinic, because with me works a psychiatrist who is an adult psychiatrist. And many times when I see a family, it's it's in your face. You cannot ignore it. And one of the things that I say to the mother or to the father at the end of the appointment, I say, maybe I think it will be a good idea to refer you to my colleague, and you should also be evaluated. It could be very helpful. And many of them take this advice, and it really is helpful.
Yeah, and that's great because you are able to, and I'm sure it's happening all the time. Your colleague that is treating adults is referring you their children, and it works great. If you aren't a doctor that treats both, then have a clinic that you can quickly get people in to get the help and not wait. For many people in the world, it's sometimes a couple years before you can get into a diagnosis. In some healthcare systems, to even get diagnosed, there's a long wait list, and it's just often not thought of. Talking about another aspect, not everybody with PTSD has ADHD, but it's much greater. What is the impact on if you do have ADHD with PTSD compared to those without ADHD? How intense are their
Well,
symptoms?
I'm not sure it is a very difficult question to answer because, again, usually we see chronic traumatic stress and not PTSD. PTSD is a very severe disorder. When you have PTSD, it's like, sorry about the comparison, but it's a bit like schizophrenia. You cannot see anything but it. It's very difficult to see anything but it because you can say that all the symptoms that you see, you can put it on the PTSD. But if we are talking about chronic stress disorder, for example, without ADHD, you won't have this kind of inattention. I will give you an example, maybe it will help to answer this question. The treatment for chronic stress disorder is psychotherapy. And this psychotherapy needs a lot of attention because you have to sit to listen to what they are telling you that is going to happen, and then you have to do it, and then you have to remember it, and then you have to train it again and again at home. These things are all almost impossible for people with ADHD because first of all they can't listen, and when they do listen, they don't remember half of the things that were said. And to train it and to do it again and again regularly, it's very difficult. So for a person without ADHD, all this part of inattention and the impossibility of being attentive, even if you want to, this wandering mind, as Professor Philip Allison calls it, this is the part that discriminates between ADHD and the severe stress disorder. And there is something else that I would like to add to. It's not only the ADHD, it is an aspect of ADHD which is very important, according to the question of resilience, for example. And this is the emotional dysregulation issue. Children and adults who are dysregulated are at higher risk to suffer from chronic stress disorder and PTSD than children because the emotional dysregulation, it's very difficult to handle. Sometimes it's very easy to confuse it with the symptoms of PTSD, chronic traumatic stress, etc. And it is also a problem sometimes that people, children especially with relation, cannot use stimulants because of the side effects. The side effects of the stimulants for them are much more severe than in other patients with ADHD because their moods and when they are trying, the stimulants work quickly and stop working quickly. And these risings and decline are very acute. And for somebody who is dysregulated, these changes, these acute changes, can trouble them very much. And then they cannot use the stimulants because they become moody, they have very severe rebounds, like that. And then you have to treat, first of all, and this is rule number 4, you have to treat the emotional dysregulation in order to treat the ADHD, in order to treat the chronic stress disorder.
It's all interconnected.
Yes, but it's like in hierarchy. If you have an emotional dysregulation, you have to treat it first because it enables to treat all the other things. And then you can treat the ADHD. And when you treat the ADHD, you can treat the traumatic disorder.
Yeah, and that's using medications like sometimes SSRIs, I assume, also with counseling support, and also then.
Not so much SSRI. As Professor Newcorn from Mount Sinai found out, guanfacine is very effective. Guanfacine is maybe the most effective medication to emotional
Guanfacine,
dysregulation.
sure.
Yeah.
And is a medication that is used especially in children with ADHD. So it's not the first line typically, but often when there's that intense emotional dysregulation that is going on, that often can be one that helps with that.
Yeah. This is not the first medication for ADHD, but it is the first medication for emotional dysregulation. And if you are lucky and because most of the children do respond to it, and if you're lucky and you respond to it, then you can add the stimulants in order to treat the other part of ADHD, the cognitive dysfunction of ADHD.
And do you think clonidine falls into that category as well?
Yes, I know that clonidine is thought to be in to do the same, but somehow it is less efficient, and you need to take a lot of pills. That you have to take like 4 to 6 pills every day of clonidine, so it's also a problem.
Yeah.
And somehow it's not as effective as guanfacine. In 80% of the children that I saw, it works like magic. And I'm not trying to give some advance to any medication, but it is really, really helpful, and it is not a psychiatric medication.
Can you say that again? 80% what? Can you say? Catch
Seems
that.
like 80% of the children with emotional dysregulation respond very well to it, to guanfacine. And it
Okay.
is important because it is not a psychiatric medication, and parents are not afraid to take it so much. When they hear that it is not a psychiatric medication, not like Risperdal or Abilify, it relieves them, and actually it is usually more efficient.
Yeah, well, that's important. I've used that especially in patients who have more emotional dysregulation. And that seems to be a little more of that intense fear response that occurs in some of my patients with co-occurring autism with their ADHD.
Yes.
That tends to have some of that more intense reaction. And it can be a big benefit, that combination of the two. Sometimes are often used. And speaking of autism, these are often missed in especially average to above average IQ kids, and they're more prone also to be having abuse happen, and that can be related to not necessarily picking up social cues. I had somebody that I saw recently who recalled as a child grandma walking in, and she was sexually assaulting a friend, and she didn't know what was going on, and walked in the bedroom and said, "Oh, what's going on?" Now this woman, now who I'm seeing in adulthood, is being evaluated and has strong symptoms of being autistic, along with ADHD, along with fibro and hypermobility syndrome and related issues, which often are highly co-occurring. She didn't know that, and she has, when I met her, she said, I've had a lot of trauma in my life. So sadly, it's sometimes interpreting some of the social things, and then unfortunately predators preying on people that may sense that there is a difference and they can get away with it. It's very
Sad, yes.
And as she now is very protective of her kids, and why we do these podcasts is that you have to even be more vigilant in talking about that with the children at very young ages, about good touch, bad touch, what's appropriate. You can tell us, because that can hopefully be somewhat protective.
Totally, completely. Yes, I agree with you completely. But you see, the problem with ASD, there is another problem that sometimes they suffer from traumas that you don't understand that there was a trauma. Because even psychotherapy could be traumatic for children with ASD if the psychotherapist is not aware of the ASD. Because the understanding and how they see and how they respond to the child is very different, and they say things that may be traumatic to the children. Because both sides, first of all, because the psychotherapist doesn't understand and he says things that are not true or not the right things to say, and on the other side there is a child who understands words on their face value. So sometimes the children don't understand a symbol or a nuance, and they understand if the psychotherapist said something, they understand it on face value, and it may be even traumatic for them. And then they have more traumas that we don't even know about.
This was an interesting shared at the APSARD conference, and I don't know if it was on one of your slides, but one of your colleagues that was presenting, is the title of the slide was PTSD is a disorder of extinction recall. And it shared that results from a 2009 study showed that those with PTSD and trauma exposed people who did not develop PTSD have comparable response during fear conditioning and early extinction, but differ considerably in recall when PTSD patients do not retain extinction learning.
And the ADHD patients have the same problem. This is what I talked about before, about networks, the hippocampus and the ventromedial prefrontal cortex. These networks are responsible on the fear extinction and the recall of the fear extinction. And this was a work by Biederman and by Biederman's crew, by Biederman's team, sorry, several years ago.
And that's the metaphor that often has been said, and a couple of my patients we talked about this week, that trauma is very sticky. If you have ADHD, it sticks to you. It's like the Velcro on a shirt. It just sticks, and it's harder to remove that, where other people, it doesn't have as much of a stickiness.
Yeah.
That's one of the things that often I wonder, it's more likely to stick with somebody. It's harder to get rid of it.
That's because I never heard this verb before, but I agree with it. I think it's partly because people with ADHD are less flexible and they are stuck with something. It's like when they're doing something and you talk to them, they cannot hear you or they hear you, but they can't understand what you say because they're stuck with what they're doing. So this inflexibility may be a problem when you have a trauma because you're stuck with the trauma and you cannot go out of it.
Yeah, it's a very attention grabbing. It's that fear network that puts you, and it serves its function to have appropriate fear. But when you are in objectively safer situations, to have the fear networks on all of the time, it's exhausting.
Yeah, it's very exhausting. And that is why the mental tiredness of people with ADHD is so huge. One of the main complaints, especially of adults, is mental tiredness. Not tiredness, but mental tiredness, although they don't sleep enough, and this is also a problem, and they are tired too, but there is also this mental heaviness, mental tiredness, because they are all the time ruminating, all the time, as you said, stuck with stuff that they cannot get to get out of it. And yes.
Last week I interviewed the head of the NIH study on chronic fatigue syndrome, the big phenotype study. They did an incredible look at people with chronic fatigue syndrome. I interviewed Dr. Young yesterday and went through that, and they did neuropsych testing, which showed that 69% reported some cognitive impairment. But of course, they only did neuropsych testing. They didn't do ADHD-based evaluations. And as Dr. Young and other studies showing very high, about 70% of them had ADHD. And one of the things that Dr. Nath, who I interviewed, who's a neurologist by background, was kind of leading the study, he said, well, there's this thing called fatigue. And that's an interesting word in the English language, because we think of fatigue medically as, well, do you have anemia and you can't walk because you're hemorrhaged and you have heavy periods or whatever? Or do you have heart failure? Do you have a pulmonary embolism or COPD or asthma? Do you have hypothyroid? And then typically what happens is they go to the doctor, they see them for a symptom of fatigue, and they're listening for that type of fatigue. And in the differential diagnosis, medical students have not been taught, or let alone doctors, that one of the symptoms of fatigue actually could be ADHD and the brain effort to do it. And adults have to do the things. If they have children, they have to do things. Otherwise, their kids will be running around in the street and they can't do it. And the kids might be taken away in the child protective services. So they're forced to do things. And the cost for ADHD adults to do the everythings of life is its mental fatigue and exhaustion, and then it shows up as this fear on guard, and often manifests one ways as pain as well associated with that.
Yes, I like the word fatigue, and I think it's a very good one, because yes, the awareness of ADHD is so low, especially among adults, that usually nobody thinks about it at all.
And it's also, I think what happens is many of my patients that I see that fall into this category, they have been to the medical system, they've had workups, and they've been normal. So they stop complaining about it and they mask this. And often because they don't want to be perceived as a hypochondriac. So a couple of questions as we're kind of getting towards the end of our opportunity to talk here. One is, there's this Dr. Gabor Mate. He's a family practice doctor out of Canada, and he has ADHD, but he's this theory that ADHD is really just caused by trauma. It's just a traumatic, and I want to ask you about that. I don't agree with it, but even though we've been talking about trauma and ADHD and these correlate, but the cause aspect that trauma causes ADHD, can you speak to that?
I'm afraid I don't agree with him. So I think it's a very psychological point of view that everything is evolved from traumatic this or traumatic that. And this is all psychology is based on. What traumas did we have as children, as infants, etc. And from my impression from my clinic is that ADHD and traumatic stress disorder are very different things. It is a vicious cycle in which one is exacerbating the other, but they are very different, and you treat them differently. So I really don't agree with this view, maybe because I'm not a psychoanalyst.
And that's a very point of view. I don't think APSARD members and the people who are in the academic world of ADHD looking at evidence-based approaches, the evidence does not support that. The evidence supports this is a biological aspect. This has been talked about that. But I know we're talking about that, and there are people who listen to the internet, and he's on the internet and touting this, has written books out there and has that. So
everybody can write books, and everybody
yes.
can be on the internet. And it's first the freedom of speech. It's a problem because, and it is even a bigger problem. Now there is this idea of diversity, and it is very people with impairment. It is very, no, I forgot the word in English. They would like to be or to feel themselves as neurodivergent, that they are different but not impaired. It's so much easier not to be impaired, but it is not real. We believe as psychiatrists, the first rule of psychiatry is being realistic. See the reality as it is. And this idea about neurodivergence, it is like a new one, but it is really new because in the 50s, they tried to do it with schizophrenia. That this is a social problem and not a real sickness. They did it with deaf people, tried to say that it is not an impairment, it is a divergency. And also now with autistic, the ASD, many people who suffer from ASD say, no, we are neurodivergent. We are not impaired. It is not. And I have a problem with it because, of course, there is an impairment, and you can see the impairment. And with ADHD, you can treat the impairment. So trying to ignore the impairment in order to feel normal, and I understand this need to feel normal, is very dangerous. I remember a child that I saw in my clinic, a very intelligent child, that told me, the biggest secret is that what all of us want is to be normal. And when you cannot be normal, I don't know what normalcy means, but there is something called normalcy. You try to find solutions to it, and sometimes solutions are dangerous if they block the possibility of treatment. If you treat yourself, I don't care how you call what you have, but you must treat yourself. Otherwise, bad things will happen.
And I try to use analogies when I talk about this as I need to wear glasses. Many people, including my father, need hearing aids. It's really hard to function, and it's a lot of workarounds we can do without our glasses and without hearing aids, and yet we're blessed in the modern time that we actually have things like glasses and hearing aids if we have ADHD. And the crisis of the modern world is cognitively demanding job. That's a challenge, and yet we know that there's a struggle. There's a lot of suffering that goes along with this. And I talk about this a lot on the podcast because it's not recognized very often. Many patients are coming to me and they're shocked to realize that, especially in adults, they've had this their whole life.
Yes.
And the therapy never worked for them. They had a lot of social consequences, economic consequences, relationship consequences, and suffering. There's that message out there that if you are a clinician and you're seeing somebody with these persistent, long, severe symptoms, think about ADHD. And if you have that ADHD, treating ADHD can help buffer from so many different aspects, healthy behaviors, that routine and schedule. And again, like you said earlier, if the family gets treated, they can help have a positive, supportive aspect. Whenever I have experts like you on, I like to finish with two things to speak to, because these are people all over the world listening, over 123 countries listening to this. So there's two groups. There's those who are living with, it's a fibromyalgia, chronic pain syndrome podcast. These are all overlapping. People often have trauma is associated with these chronic pain syndromes. So one, can you speak to people who are listening, who are living with this, or are caring for somebody in their family with this? And then speak to clinicians, the medical doctors, the psychologists, and the therapists out there who are treating them. So what of thoughts and speaking to them?
ADHD is an impairment. I also use a lot the example of glasses because, as I said, and I think that ADHD, if you young age, it has an excellent process. I know patients are not so young anymore, and I know patients that as children had a lot of problems, and now they are adults, happy adults with full life, married, having a very good job, academy without any problem. So the prognosis is excellent if you treat it. If you don't treat it, it's dangerous because it's like gambling on your life. It's like gambling on your quality of life. You have a lot of problems that you may deal with, and it's dangerous. And I think it is not a good idea not to treat when treatment is so easy to get, and when treatment is usually very, very favorable, very efficient, and without many side effects. And you have to be very consistent and very persistent and try to find the best treatment. And if you have side effects, not to give up, but to try to find a better medication, a better treatment, not to listen to all these charlatans who sell you, like other treatment that cost a lot and doesn't do much, but take the evidence-based treatment. And I think this is the most important thing, that it is something easy to treat, very favorable prognosis, and I don't see any reason not to treat it like you treat hypertension, like to treat diabetes, like to treat epilepsy, all of which, by the way, are somehow related to ADHD. So it is an important issue. And this is what I say to the physicians too, because the only thing I have to say to physicians is be aware, because the problem is lack of awareness. And too many times, physicians don't think of ADHD. Not when they see in the emergency room somebody who attempted suicide, not when they see an obese person, not when they see a diabetic person, asthmatic person. I can give a list of other problems. It is highly important because it's not only for the knowledge and the awareness, but because treating ADHD helps treating other problems, other medical problems. And ADHD is medicine. It is not psychiatry. It is medicine. Because, psychiatry somehow is looked upon like it's not medicine, although it is. But it is really medicine because it's related to so many medical problems that you have to study about and you have to learn about, and many physicians don't even realize that they are connected. That I think that the awareness of it is highly important.
Well, thank you so much for time with us and sharing your experience and wisdom with the listeners out there.
Thank you for accepting me.